Good evening, everyone. My name is Krista. I'm with Cornerstone Adminisystems. We're a third-party EMS billing agency. And whether you're aware or not, for several years now, Calvert County has been discussing with Cornerstone implementation of billing patients' insurance as a method of cost recovery for services that you guys are all providing in your communities. It's no secret that healthcare continues to balloon with costs, and not only for patients, but for those providers like yourselves who are out there day in and day out, providing those services, keeping trucks on the road, equipped, staffed, etc. So cost recovery, which we're going to talk a little bit about within the presentation tonight, is one way that services, such as all of the departments that are participating, can get back a little bit of money to help keep those services going. There will be dedicated Q&A at the end, but if you have like a real pressing question or something is confusing, just raise your hand and we can kind of cover it there. But other than that, I would just say we'll do a formal Q&A at the end. That way they can capture that for the recording for those individuals that might not have been able to make it tonight. Before we get started, just a couple of things that I want to point out. Cornerstone has been in this weird little niche industry business for 30 years. We're celebrating 30 years this summer. We're founded and continue to be located in New Cumberland, Pennsylvania, which is right outside our state capital of Harrisburg. I'm no stranger to government. I spent 20 years working in the state legislature, so I'm very familiar with red tape and bureaucracy and public broadcast. So it was a nice transition to me when I joined the Cornerstone team about 4 years ago in our client services division, which I spent doing client services work for about 2.5 years before moving in and taking over our sales position. So I get to talk to agencies of all different sizes. Myself and my colleague Travis, who oversees our client services division, we do iterations of this presentation at conferences, other stations, large stations, small stations. But as I mentioned on Tuesday night, some of the material in here is newer. We've been working to update statistics. We've added some general cost recovery stuff. Because of time constraints and we want to reserve time for Q&A, there are some slides we're not really going to kind of go over tonight just because they don't really pertain to the delivery of 911, which is what we're going to focus on. But the presentation will be intact in all of the copies that are going to be shared with the department. So if you're interested and you want to go in and you want to read more information on non-emergent transport, et cetera, you'll have that at your disposal. So, all right, let's get started. We're going to talk about a lot of different things tonight. I'm not going to read every slide verbatim. I'm actually just going to wing it, but you can follow along if you want. But generally speaking, we're going to talk about a lot of different things, basically starting from EMS as a whole with scrutiny and oversight from the government. We're going to talk about, as you can see here, understanding the role of the patient care report, the PCR. That's going to be the nuts and bolts of the center of the presentation. We're also going to talk about some supporting documentation, but again, we're going to scale that back a little bit to focus on the 911 components. And then finally, we're going to talk about some fundamentals of good documentation and why it's important. One of the things that I want to list as kind of like a side note is the information here, some of it for a lot of you will be well known or familiar, but we're presenting it to you from the lens of a biller. We're trying to make you understand why the details that you collect on any call become important to those behind the scenes who are doing the billing for you so that you can get paid. So when we get into things like reviews of level of service and stuff like that, for those of you that that's very familiar to, just understand that we're reviewing it as a way to explain how we use it in billing. Okay. General legal disclaimer stuff. We've already given authorization to have this recorded, so. All right. So section 1, we're going to talk, and we're going to try to go through this pretty quickly. It kind of went long the other night, so I don't really want to spend too much time here, but it is important. We're going to talk about EMS, we're going to talk about fraud and investigation, and we're going to talk about that under the umbrellas of like the large oversight jurisdictions that carry that. We're going to talk a lot about Medicare and Medicaid before we get into the other payers, and I'll explain why when we get to that part. We're also going to talk generically about cost recovery, and then we're going to move right into the patient care report segment. So EMS under scrutiny. As you can see from the statistics up here, healthcare spending is, as you can imagine, out of control. I think the latest statistic that we were able to pull in the US, it yearly surpasses $4.5 trillion. Medicare alone is $944 billion a year. That's a pretty astounding number to kind of try to grasp in your mind. Medicaid spending is $805 billion. Payments by government programs are, particularly with the commercial insurances and the federal entitlement programs, more than ever are looking for ways to cut costs, make sure the spending is efficient, effective, making sure there's no erroneous reporting and or funding. So more than ever, they're looking at not just EMS, but healthcare in general for ways to try to shrink those expenses. Problems ranging from simple errors in claims reporting are a large contributor to how the government tries to pull back some of the money. So we will talk a little bit about that in the presentation. More than ever, these state and federal governments are allocating more resources to investigate claims, fraud, etc. Most of this, like I said, you'll be able to access. What I want to draw attention to here, though, is that the audits and investigations of Medicare and Medicaid-related billing, they actually can be initiated by a number of different organizations in particular. So like sometimes the federal government is overseeing, but sometimes state Medicaid programs have their own programs in place because Medicaid, excuse me, in and of itself, while a federal entitlement program is administered by the states. In the spring of 2023, the OIG, the Office of Inspector General, released that it expected to recover nearly $12 billion from audits and investigations. Now, I do always like to do kind of an aside here because we do talk about audits and investigations a lot at the front end of this. The very nature of getting audited as an agency is not necessarily a super frightening thing. Audits are commonplace, particularly Medicare and Medicaid audits. So I will talk a little bit about that as we get in. But when we're talking about these big numbers here, these are like large scale bad actors, hospital-based, large non-emergent transportation entities that, were filing fraudulent claims because they were for transports that were never done, et cetera. So just getting an audit doesn't mean that it's a terrifying situation. We're going to talk about the fact that there are several different federal laws that the government uses to basically prosecute fraud investigation. The two main ones are the False Claims Act and the Anti-Kickback Statute. We're not really going to go into much detail on any of these, but just to point those out, and then we're going to talk a little bit about that exclusion statute. The laws basically outline those administrative and civil penalties, and in some circumstances, criminal penalties for violations. Government agencies that include the U.S. Department of Justice, U.S. Health and Human Services, et cetera, they're the ones that oversee and enforce those laws. So the False Claims Act is exactly what you would expect. It's basically knowingly or causing the submission of a claim that's fraudulent. This could be for any number of things. I referenced earlier filing claims for transports that never occurred. It could also be knowingly and causing submission of a claim for a level of service provided that was not accurate. That doesn't mean that from time to time claims are filed for an advanced life support service, but really BLS service was what was provided. That's not always a crime there. Sometimes it's just misunderstanding the documentation that's in place, so we're going to talk about that. Penalties range basically from fines, usually 3 times up to the amount, for civil penalties under the False Claims Act. There's also a criminal False Claims Act, but again, that's going to be for your really large-scale abuses of the system. The anti-kickback statute is exactly, wow, that sounds, it's kind of like I scratch your back, you scratch mine. Basically, it's just if you knowingly or willingly offer to solicit A good example of this is, a provider taking patients to a particular facility in exchange for reduced, rent or, monetary kickback, etc. So again, the False Claims Act and the Anti-Kickback Statute are the two primary pieces of law that the government uses for oversight of fraud and investigation. The OIG keeps a list of excluded individuals. So these are individuals who, for violations under both of those and some other permissible violations, it's like Santa's naughty list is what I like to call it. They're all the bad actors that you should not be hiring to work for your organization. So if you have a rainy day and you're bored and you want to look up to see who some of those individuals are, we have the link right in here, but they do keep a list. And I can't remember how long you stay on the list. It probably is handed down with the penalty and the punishment. But if you knowingly hire an individual or entity on the list, you also can be culpable. So, if you're someone who handles a lot of the management and the hiring, it's always a good idea maybe to kind of check this list just to make sure you don't recognize any names on it. So why EMS? One of the things, EMS is to be honest, is like a small piece of the overall pie of healthcare fraud and investigation. And even though the money in that pie doesn't seem like a lot compared to the whole, it's still a heck of a lot of money to the industry itself, which is why we feel it's important to talk about. The lack of medical necessity or poor documentation, and then, of course, with the fraud among the bad actors that I mentioned, those are the big pieces that really kind of continue to spur movement and direction for oversight in this area. But a lot of this stuff is preventable. And so we do want to talk about how documentation plays a role and how you can be sure that you're covered in the role that you're playing. I mentioned earlier, Medicare in particular, I alluded to the fact that getting audited by Medicare isn't necessarily a scary thing. The reason why is Medicare does what we call post-payment review. So when a claim is submitted to Medicare, they assume that everything that is necessary for the claim and all of the information provided with the claim is accurate. And so what they do, unless something is glaring, like a missing signature or a field that like mileage or something is not there, they're going to process it assuming that it is accurate. But then what they do is, after a period of time, they go through agency by agency and they'll do random audits, and they'll send either the agency, if they do their own billing, or the third-party agency who's doing the billing for them, a list of like 20 or 30 calls to go back in and re-pull all the documentation and supporting documentation as part of an audit. And they re-review those. They look at level of service that was provided and paid, etc. And usually I would say in an audit, typically the ones we've seen, out of 20 trips, maybe they determine 3 were paid out at a higher level than they should have, and so they'll take back a couple $100. That's not the fraud and abuse we were talking about here. Those are commonplace. So as Calvert County gets into billing, if you suddenly get a Maryland Medicaid audit or a CMS Medicare audit, it's not automatically a sign of danger. It's actually rather commonplace. I'm going to talk real quickly about the Medicare Recovery Audit Program. Basically, recovery audit is just conglomerates, teams, if you will, and they're the ones that are conducting the audit investigation work for Medicare. They're grouped geographically in large areas, and they're awarded out to contractors, so large-scale agencies that kind of handle that for them. As you can see, for some weird reason, Mid-Atlantic over here got piled in with the West. Not quite sure why, but it is what it is. But those teams are the ones that are going to carry out those audit investigations. There's also Medicare Fraud Strike Force teams. These are community-based, and they pull together resources, state, federal, and local, again, to examine and investigate fraud at all levels. I have a map in here if you're interested in where some of them are located. You can go in and kind of look at that information. But for our purpose tonight, not super important to focus on. Actually, I'm going to back up real quick. Cumulative totals through September 2022. Criminal actions from these task force have been 2,688. indictments have been over 3,000, nearly 3,400. And investigative receivables, that means money coming back, has exceeded 4.7 billion. So it's nothing to sniff at. I mean, they're definitely, their investigations are recovering money, but yet still for me, as someone who comes from government, a little bit less than I thought it was going to be. The ET3 model, I don't know if anyone in the room is familiar with this, the Emergency Triage, Treat, and Transport. It was a pilot program developed by Medicare, the Centers for Medicare and Medicaid Services, CMS, so I usually just call it CMS. They developed this as a pilot payment model that they were working to try to find ways to pay out claims to pull necessarily from bringing patients automatically to ED. So they were authorizing transport to alternative destinations like urgent care clinics, etc. It was supposed to be a 5-year program. They actually ended it in December due to lack of participation. I think it was a little clunky too. I don't think it was properly thought through the way they were trying to push it out. We have a New York billing partner who was trying to do a little bit of telemedicine through the program. We had it set up to try to do it, but it really wasn't clear, the parameters of the program. They ended the program, but I do think one interesting thing to note is that every year Medicare pushes out new guidelines regarding their billing procedures, regarding their fee schedule, etc. And there has been some expansions in those areas. So I do think they took some lessons from ET3 and are slowly trying to implement them in other ways. And I think ultimately we will see a larger move in that direction. The Medicare ground ambulance cost data collection it's ongoing, is a program that is designed that requires EMS agencies across the country to participate, and for 1 year, either calendar or fiscal, they have to gather all of their data regarding their expenses, their revenues, their rent, electric, supplies, staff, everything. They have to gather information about that. And then in the first quarter following their reporting year, they have to report that information to Medicare. If you were chosen to participate in the program, and to be honest, pretty much every ambulance company across the country was required to participate at some point, unless you're a hospital-based entity. But if you failed to comply or failed to report, you were going to suffer a 10% reduction in Medicare funding the following year. So every claim that you billed out to Medicare, if they were going to pay you $100, they were going to knock that down to $90 automatically. So we actually did have some billing partners that said, forget it, we're not even going to worry about it, we'll take the 10% loss. But for a lot of agencies, that 10% is needed. So they were going through the hassle of trying to catalog everything. There's a heck of a lot of information about this on Medicare's website. I have some link here too if you're interested in reading more about it. But essentially the program's mission was a response to the industry that basically said, you guys keep saying you don't have enough money to run, we want you to tell us. Now, whether we'll see anything from this, I don't know. I tend to be a little more cynical on that side. But the hope is that they will take the data that they're getting back and make some serious changes to the fee schedule. All right, so looking ahead, what's next? All signs point to movement towards, even though ET3 failed, essentially, movement towards a system that is based on quality and access to care as opposed to fee for service. That's the hope. We'll talk briefly about the fee schedule and how it really does not do a heck of a lot of help for a lot of agencies. So we're hopeful that Medicare taking some initiative to really try to move and look at new directions to do things to streamline access will be better for the agencies involved that are providing those services. I do want to point out that it changes all the time. Our team, we're constantly sitting through webinars, going to conferences, educational stuff to stay abreast of all the changes, not only in Medicare, but in Medicaid. And as I mentioned earlier, Medicaid's administered by the state, so we have to follow whatever state we have billing partners in. We have to make sure we're up to date on that state's Medicaid changes as well. We had big changes in Pennsylvania this year. We used to be very limited in the mileage we could bill to our state Medicaid. They got rid of that. They actually gave a pretty good increase. So we have to be abreast of all those changes, and it's not only just from the policy side as we're keying out trips, but like our systems people need to know that to make updates to our billing system, et cetera. So a lot of stuff goes on behind the scenes, a lot of continuing education required, which is why a lot of agencies go and outsource their billing, because they don't have the time to do all of this in addition to providing good quality care. So that's why we're taking on the responsibility of trying to keep up to date on all of this stuff for you. Okay, so we're going to talk briefly about cost recovery. As I mentioned earlier, it's cost recovery is a kinder way of talking about billing. So at Cornerstone, we bill for all kinds of agencies. We have agencies that we call full cycle revenue recovery, and that's up and through sending patients to collections if they don't pay. But a lot of agencies in communities like yours prefer a softer approach. So there are soft billing models that are generally recurred cost recovery, where we're collecting patient information and we're billing the patient's insurance. But if the insurance doesn't pay the whole bill, we're just writing that off. The patient, him or herself, is not going to collections for anything. The only thing that they might get in the mail is communications from the biller about, hey, we need your insurance information, or we need a signature for you. But any kind of cost sharing that's attributed to them, they would not be liable for. And we see that a lot in states like Maryland, New Jersey, and Virginia. Those states tend to favor more of a soft billing approach, largely because, frankly, you guys have better community support. In Pennsylvania, we have a lot of small rural agencies with very little community support, so they kind of have to go after the whole thing, because otherwise they wouldn't be out pushing their trucks around. So because of that, we wanted to just talk a little bit about the model that Calvert has chosen, and that I believe we're scheduled to go live on Monday. This has been kind of in the works for several years, but essentially the way it'll work is when a patient's taken to the hospital, information is gathered when it can be, but the hospital's also formed a partnership to pass along patient information to us as the biller. And when those charts come over to us, we're going to bill them out to the patient's insurance on file. And then when the money comes in from the insurance, we'll post that. And anything remaining gets written off. Different write-offs. If it's cost sharing, it gets written off to what we call community resident. If it is what we call a differential, meaning it is the amount that is between the charges and what the insurance is authorizing, we write that off to a no bounce billing differential. But at the end of the day, your patients who are community residents aren't getting billed for any kind of remaining money owed on the account. Now, non-residents, on the other hand, those who are visiting the area, they would be subject to full cycle, so we would be reaching out to bill them for their share of the costs. But again, in Maryland, because there's no balance billing, they would only be billed for their cost sharing. So that's just a quick look at cost recovery. Medicare is the pickiest with regards to what they need to see. Every Medicare claim has to come with a patient signature, so we're going to talk a little bit about that. Okay, so there are 4 parts to Medicare. There's Medicare Part A, Part B, Part C, and Part D. Part A is like major medical for a Medicare recipient. So that's going to cover hospital stays, etc. Part B, that's their outpatient services, and that includes their transport. So as an ambulance billing agency, we bill under Part B of Medicare for your Medicare patients. Part C is Medicare Advantage. That's like a Medicare HMO. It's Medicare with bonus benefits if the subscribers want to pay for those. And then finally, Part D, that's optional prescription coverage for a Medicare beneficiary. So again, for us as a biller, we're really only concerned with Part B and then Part C for those patients that have Medicare Advantage plans. I have the links in here both to the Medicare, to the government's like, here's information about Medicare website, so you can link to that, and also to the CMS actual website where we'd link you to deeper level stuff like provider requirements, enrollment requirements, etc. Now, while Medicare is a federal entitlement program run under CMS, Centers for Medicare and Medicaid Services, the actual day-to-day administration of the program, similar to the audit stuff that we saw early, is done by teams and is contracted out. So as you can see from this colorful map, there are a number of Medicare contractors. They're called Medicare they're called Medicare Administrative Contractors. We call them MACs. Actually, I have some good friends that work for MACs. And the one in our jurisdiction is Novitas, which is actually in my backyard. It's located in Mechanicsburg, Pennsylvania. That's where they're headquartered. So Novitas does all of the claims filing for most of our clients. But as I mentioned earlier, we do have billing partners in other states. So we work a lot with WPS because we have some Midwest clients, Palmetto down south, and NGS to the north, National Government Services. So just like Medicaid, we also, while Medicare has standard rules in place, the MACs may administer them slightly differently with regards to enrollment, et cetera. So we have to stay abreast of all the different nuances from the MACs as well. One of the reasons why we do spend a little bit of time about Medicare billing in and of itself is because the other payers, Medicaid and commercial payers, tend to look to Medicare as the parent. Like, if it's good enough for Medicare, it works for us. It doesn't necessarily mean that all the things that Medicare requires apply to those payers, but they're going to use similar standards with regards to, you know, they're going to pay mileage, but they're going to be earmarking it sort of like Medicare does, where limiting it to the closest appropriate facility, et cetera. So while it's a harder, fast, strict rule in place for Medicare, again, those other payers do look to that as setting a guideline. Now, with Medicare, there are a few things that have to be in place. So number one, all claims have to be filed within a year. And there are instances where I have literally submitted a claim to a payer on like day 364. You'd be surprised, but it happens. All claims must include a clear and detailed patient care report, which is your role. All Medicare claims must include an approved patient signature, which we're going to talk about. All Medicare claims for non-emergent transport must include a medical necessity statement. We're really not going to get too in the weeds of that tonight because it sucks up a lot of time, and I know that we're really focused on staying kind of in tune with time tonight. And finally, some Medicare claims, namely repetitive transport patients, require a CMS prior authorization approval. Again, we're really not going to delve into that one tonight. But we're going to take a look at patient signatures because that is important. And then I wanted to kind of harken back real quickly because I mentioned the fee-for-service schedule. So for those of you who are unaware, Medicare pays out, and Medicaid as well, pays out by a fee schedule, meaning it's a list of amounts that they've said year to year. This is what we will pay for A, B, or C service. So let's say standard basic life support emergency service. This is the area you live in. You're in this locality. That's what they call it. We're going to pay you, $450. It doesn't really matter whether you charge $800, $1,000, $1,200 for that service. Anyone who's in that locality, in that jurisdiction, is getting paid $450 if they're doing a basic life support emergency transport. They do the same for all levels, especially care transports, mileage, et cetera. Mileage usually pays between $7 and $8, over $8 if you're lucky. So the fee schedule, again, is announced every year. And there's all kinds of like weird terminology. There's sequestration and stuff. We're not going to get into any of that, but it affects how the actual what they pay comes out on the schedule. So they may say, well, we're approving this, but we're applying sequestration, and there's all this math that's done behind the scenes. So it can get really convoluted and confusing. One of the things that we do at Cornerstone is our VP of Business Development, she every year, once the new fee schedule is announced, she goes through and applies those calculations state by state. So we have nice, tidy sheets for each state that we bill with to really make it very clear, hey, if any agency in Maryland calls me up and needs to know what the current Medicare rates are because they're looking at changing their charges, I can provide them very quickly with a good tutorial on that. So again, it's not, it's a little complicated, but the point at the end of the day is to just keep in the back of your head that you can raise your charges all you want, but Medicare's still only going to pay what Medicare's going to pay. And Medicaid is the same way. They also operate by a fee schedule, but it's done again state by state. Medicaid state administered rules, these again vary. So common variances would include eligibility, submission guidelines, scope of services. So in Pennsylvania, we have a 180-day timely filing requirement, meaning for them to consider a claim, it has to be filed within 180 days. Maryland, I did a nice little quick sheet for you guys. It's actually 365 days in Maryland, which is nice, better than New York, which is 90 days. But Medicare recipients typically have to be pregnant or responsible for a child age 17 or younger, or have a disability or a family member with a disability in the household. So the restrictions of Medicaid in Maryland vary a little bit from Pennsylvania and New York. Generally, all three programs, though, seek to provide some sort of health coverage to low-income or disadvantaged individuals. Again, as I mentioned, in Maryland, all claims have to be filed within 365 days, and you must include, obviously, a patient care report, but they do not require a separate Medicaid Maryland signature, where Pennsylvania, we have to not only have a regular paperwork, we also have to have what we call a Medicaid waiver. So again, small nuances that vary from state to state that if you are billing in more than one jurisdiction, you have to be mindful of. So now we're going to talk a little bit about the PCR itself, but we're going to look at it through the lens of that it serves more than the purpose of healthcare delivery. For sure, that primary purpose is it's a medical record, right? It's for QA, but it's also a legal document. It's also a basis for reimbursement, which is my job, and then it is a source of data collection. So when we look at it tonight, I want you to think about it not just from this day-to-day of recording a history of a call for the patient, but think about where that chart goes down the line too and how it's used in many different ways. So because of that, we're going to focus a little bit on levels of service, coding and billing, fundamentals of a PCR, the logic of writing, and documentation best practices. So the level of service, a lot of this will be a reminder for you guys. But we're going to talk briefly about emergency versus non-emergency, and we have a very silly description of that for you. BLS versus advanced life support. We're going to talk about the ALS assessment rule from the billing perspective and why that's important. And then we're just going to breeze right through ALS level 2 and SCT. So an emergency, generally, and obviously different jurisdictions and protocols may have small nuances, but generally under Medicare and other payers, for it to be considered an emergency, it must follow these things. It requires an immediate response to 911 or equivalent dispatch. And that just, immediate just means that you took steps to respond in an immediate manner. Obviously, there are things that need to be in place. So, if you get out the door in 2 minutes as opposed to 4 minutes does not change it from immediate to non-immediate. Regardless of the medium in which the call is made, if the call is of emergent nature when based on that information warrants that emergency dispatch and the crew leaves with proper crew in place to respond to that call, then we can bill that as an emergency. The use of lights and sirens, not a determining factor. Not emergency is honestly any ambulance transport that does not meet the definition of emergency. So there are scheduled and unscheduled non-emergent transports. And those are, as I mentioned earlier, there's a lot of specific provisions and documentation requirements for non-emergent transports. So again, they're all included in this presentation, but we're really not going to focus a lot of time and attention tonight just for time purposes. Heightened emphasis on medical necessity for non-emergent, because they're always going to want you to answer the question and paint a very clear picture. Why did the patient have to be taken by ambulance as opposed to another mode of transport? So for BLS, for basic life support, 911 or equivalent, and the same, as you can see, the top are the same for both basic life support and advanced life support. You have your 911 or equivalent dispatch, meeting that definition of emergency, meeting the definition of immediate response, and the only changes, frankly, comes down with making sure the proper crew are in place. And again, those titling and naming conventions for crew might vary a little from state to state, but generally speaking, they're widely accepted. We're looking at EMT, paramedic, we're looking at AMTs now, intermediate, advanced, depending on which jurisdiction you're at. And then in an advanced life support transport, we're paying extra attention to the assessment and the interventions that are being done for billing purposes. So the ALS assessment rule, this is really important, and this is why. So if you have an ALS dispatch and the team's report, now if it's a MICU situation where everyone on board is tied to that truck, no one's going anywhere, if the patient's doesn't need ALS support, they're still all there, that we don't really need to worry about that, because no matter what, that chart's getting done by the team that's on that truck. But when you have mutual aid calls, whether it's the same agency is bringing two teams together, meaning like a Chase paramedic and a BLS unit, or you have a non-affiliated agency meeting up with you for mutual aid response, and you have the BLS team and then a medic coming on scene. If the medic if the dispatch was ALS level dispatch, the medic is there and does an assessment, but ultimately determines, you know what, the patient can go BLS. I'm going to free myself up to go to the next location where I need to be. If that individual prepares the chart that documents the ALS assessment was done, we can joint bill that call if a joint bill is in place. Or for Calvert in particular, since you have Chase medics around the county, if both charts are done, if the medic's chart is done and the BLS transporting agency's chart is done, even if the transport was ultimately BLS, we can bill that as an ALS call. Again, it needed to be an ALS dispatch, and the ALS level assessment needed to be done and documented. If after that assessment is done, the paramedic rolls on to the next call, that's absolutely fine. He or she does not need to stay on the truck to go. It's just an important distinction to make, because we see a lot of agencies just cancel the ALS after an on-scene assessment, and then they're billing it BLS and they're missing a little bit of money there. So it's just something to think about. So if you have questions about that after this, I'm happy to kind of review that with you. But we do like to drive that point home. ALS level 2 is exactly what you would expect. To be classified as a level 2, our coders are just going to look very closely at those interventions that are documented in the PCR. We're going to want to see some administration of medications and or one of the things mentioned here. So anything from a surgical airway to cardiac pacing and more. If we see those things documented appropriately in an ALS chart, we're able to up that to an ALS level 2. Now, what does that mean for you guys? It really depends on whether the agency has differentiated the charges between ALS 1 and level 2. So that's where we're at with that one. Same as specialty care transport, but we're going to look heavily at the crew here, because the specialty care transport is going to require a medic with expanded scope of practice or even higher to be on board. Usually we see this in interfacility transports. So a lot of non-emergents, there tend to be the SCTs. And if it's just a patient sleeping by themselves in the back of an ambulance, that does not qualify as an SCT. Let's see. It's about 6:38. We're going to get into this a little bit, and then we'll take a quick 5-minute break so that you can stretch your legs, get a little water, get a snack, and then we'll move in and kind of tie this up. So I'd like to open with a little bit of overview of what a coder sees behind the lens. So coders are those individuals who for 8 or 10 hours a day or however long they're working are taking the data that you give them in your charts and transfiguring that into codes. There they all go. Transfiguring that into codes for billing purposes. So I like to use the analogy that the ICD-10 codes for injuries and disease are designed to create specificity. I'm gonna wait. We're going to go ahead and resume just to try to keep on track. It is getting recorded, so as people trickle back in, if whatever they miss, they'll be able to watch. But I don't want to wait too long, just because I know everyone wants to get out of here too. So before the break there, we were kind of just venturing and dipping our toe into the waters of documentation coding. So bear in mind, you don't need to leave here tonight knowing how to do any of this, but we include it because we think it's important to distinguish how your detail and the detail that you guys put in your charts is used by billers to make sure that a claim is entered and submitted correctly, but goes way beyond that. The more specific we are in our records, the better for continuing patient care down the line, particularly in more severe cases and trauma where your chart is just the first step in a patient's long healthcare recovery journey. So we talk a little bit about the coding and what it looks like from our side. So generally, we're using the International Statistical Classification of Diseases and Related Health Problems. I can never remember that by heart. But we call those ICD-10 because we're using the 10th revision. And those are used fairly commonly across the globe, really. But these are scores and scores and scores of very, very specific alphanumerical codes that basically are used to describe that patient's condition. So in ambulance EMS coding, we're using reported condition as opposed to diagnosis. So ambulance coding differs from medical coding and et cetera. It's a very niche business. Like our coders are certified ambulance coders. So they couldn't necessarily go across the street to a hospital the next day and immediately know how to code a hospital visit. So because of that, we're going to walk through what a code looks like. We have a couple of examples for you, but I use the analogy of describing this as all of these codes are seven digits or characters, we'll say, alphanumeric, and they start very broad at the beginning and it gets more specific as you head to the right. So I use the analogy of you're going to a concert. So the one on the far left, that's basically the act you're going to see, right? And then that second one, let's think of that as the venue you're going to. And then the third one is, well, that's where you got to park when you get to the venue. And then the fourth is the gate and the row and the aisle, et cetera, till you're at your seat here at the end. And if you think about it that way, you'll see in the few examples that we've included how that comes to play. So essentially, like I mentioned, we're not really going to focus heavily on the codes. That's our job. But putting it in this context will help you understand that every bit of detail you add helps us choose the code that is even more specific to that patient's condition. So as I mentioned my colleague Travis earlier, these are his least favorite slides, these first two, because he hates snakes. But as you'll see here, this particular code is for toxic effect of unspecified snake venom, accidental unintentional initial encounter. So these codes have a lot of different things. They're talking about the category, they're talking about the etiology and the anatomic site, and then it gets down to the episode and injury at the very end. So you'll see that T63001A, again, is that toxic effect of unspecified snake venom. So when you don't know the type of snake that bit the patient, etc. But if we go forward here, we've only seen one digit change, right? But now we know that it's a rattlesnake. So we're able to more correctly identify the rattlesnake venom. That's just a very small glimpse of how specificity can change in coding. And it seems very, very, I'll flip back. Again, it's very... One character has changed, and that's just because we know the venom. Keeping that in mind, my least favorite slide is a spider up here. So the T63 is not moved, but again, now we have a 3 here in the fourth spot. So we've moved away from snakes, and now we're in arachnids. So it's just, these are the codes that we use day in and day out to talk about patient condition. We have a toxic effect of contact with venomous toad, assault, initial encounter. That'd be something to see, I think. And again, the T63 has remained unchanged, but it's getting a little funkier at the other end here. So we have a couple of fun ones up here for you. Activities involving arts and handicrafts. We have bitten by a pig, initial encounter. Bizarre personal appearance and problems with in-laws, which if you've ever been at Thanksgiving in my house, would be that fourth one. But the one thing I point out down here in the bold is, all kidding aside, while there are hundreds of codes that we could use at any given day when entering a trip, we tend to see the same ones over and over again. And a good one is chest pain unspecified, which is R079, shortness of breath, leg pain, etc. But as we move a little bit forward and we're talking about detail within the context of the chart, it's much better to be able to code a claim with upper left leg pain as opposed to leg pain. So those are the things that we want to be thinking about as we're moving forward. So the fundamentals of the PCRs, we're going to kind of look, starting from the demographics and insurance, we're going to look at times and the lovely odometer through the narrative, and we're going to think about all the things that are important. The demographics, now you have all been blessed by having a good partnership with Calvert Health. It's going to be sharing a lot of patient information, but day to day, when you're out and you're dealing with patient care, this information is what your biller uses really to be able to bill correctly and accurately, an accurately spelled first and last name, date of birth, the person's address. The address is going to be important because we need to know if they're a resident or not. That's going to determine how we bill. The date of birth and the social security number with the person's first and last name, Those are critical pieces of data that allow us to, when the patient has been unable to provide insurance, and even if it slips by the hospital, if the hospital doesn't collect an insurance card, if we have that data, we can do a lot of scrubbing to find insurance for that person if it's out there. Without a social security number, though, we're going to have very little luck. Phone numbers are great, but getting copies of that documentation is always preferable. Driver's license, auto insurance are important in an auto vehicle accident. And finally, that hospital face sheet, which again, that data is going to be transferred directly from Calvert Health. But bear in mind, if you're transporting a patient to another destination, that agreement is not in place, at minimum, it wouldn't hurt to try to request a face sheet so that you could get that information. The times, you're going to look at a lot of different times on a chart. Dispatch, when you go en route, when you arrive at scene, time of patient contact, or if there's no contact, then you note that, when you're departing the scene and when you're at the destination, and when you're available again. So all of these times are important to capture. Now, something I didn't mention the other night on Tuesday, interesting the way billing works. So if you arrive to scene at like 11:45 on a Friday night, but the patient's not loaded and the wheels aren't turning until 12:10 the next day, the date of service becomes that 12:10 day for billing purposes. So that's why times are important, because the claim could get denied for incorrect date of service if we're not paying attention to those details. So those are things to think about with regarding why timing is important. The odometer there, I get asked this a lot, like how should this be tracked, etc. Medicare requires to the fractional tenth, meaning 27.2, or even if it's a 0, 30.0, they want mileage to that fractional tenth. And so because of that, the other payers are the same way. So all of your mileage should be tracked that way. Now, whether you are doing navigational and just including a total, whether you're doing step-by-step, that's your protocol and for your divisions to figure out, your best practice. But I'll just, state my case of the more information, the better. So the one thing to consider if you're relying just on a total from a navigational point of view is if you had to go out of your way to reach that destination due to unforeseen circumstances, you're definitely going to want to capture that into the chart, because Medicare is going to run the numbers and say, well, the distance from that place to this place is 4 miles. Why did it take 8 to get there? Maybe a tree was down and you had to go another way. Like, make sure you're capturing that if you're going solely based on navigational information. That can be important, believe it or not. Narrative. So we're going to talk about the narrative is really going to be where you paint the picture. And we always encourage a masterpiece as opposed to a quick stick figure cartoon. But you're going to want to make sure you're emphasizing those key points, including those details, but stay clear and concise. Like if it's not necessary, keep it out of there. But at the end of the day, if you did it, you want to capture it. If you didn't do it, it shouldn't be anywhere in the PCR. And those are rules to live by. So kind of drilling down to the details a little bit. A lot of this stuff you pick up when you're getting certified, so we're not going to spend a lot of time, but remember with laterality and location, when the patient's condition, think of the where and tell as much as you can. I used that example earlier, the leg pain. Is it up or is it lower? Is it left? Is it right? And then, we're going to get into the discussion on pain in and of itself. But think about words that you can use to make sure that your PCR is really laying it out and making it clear what that patient is experiencing or at least perceives to be experiencing. Same goes with your location. And we have a lot of the $50 words up here, but you can use front, back, left, right, whatever you're most comfortable and becomes natural for you to write. It's less about impressing us with big words and more about just being specific and clear. The etiology can be important, particularly with trauma and like an accident, like a mechanism of injury. Capturing that kind of history in your narrative is always a good idea when it is available to you. These are often will be circled back to for subsequent transports, if a patient has to go for continued care at another facility, etc. So when you can include these things, if you have that knowledge, including that in your narrative is always super important. We talk a lot about chief complaint, reported complaint, the different types of complaint. Um, the in billing, the one at dispatch, the chief complaint at dispatch, the reported complaint at dispatch, is what we use as the guide of what we can bill for. So, for instance, we talked a lot about ALS being downgraded to BLS earlier. If the dispatch was, chest pain because the patient feels like they're having a heart attack, and, maybe the dispatch is asking if they can breathe, and they say no because the pain is just so much they don't feel like they can breathe, but they don't know how to describe it accurately. You get to scene, and the person's just experiencing really bad back pain and maybe mischaracterized, but was still talking about how they felt. But now the call really isn't a need for ALS. The BLS is fine to transport because the initial complaint at dispatch warranted that ALS response. That is why we're able to bill at ALS once that ALS assessment is done and documented. So they all kind of play together, and that's why they become important pieces to the big puzzle. So again, complaints are good to capture. So in addition to what's reported at dispatch, you want to talk to the patient when you're on scene and kind of capture what they're saying there. See if there's any kind of change or discrepancy. Severity, this is pretty basic stuff. Interesting little tidbit here, the National Institutes of Health estimates that acute pain and expectation for you to be able to manage that acute pain is one of the leading primary reasons why EMS gets called in the first place. Pain and the perception of pain causes a lot of psychological and physical impact on a patient. So pain assessment can be difficult. It can be subjective in a lot of ways. So it should always be based on a number of factors, thinking about the patient's age, their injury and ailment when you're kind of doing those assessments. And there are different ways to think about pain. You have your qualitative scale, your 0 to 10. Quantitative. You have your qualitative where you're talking about the descriptors of pain, sharp, stabbing, aching, etc. Thinking about is it intermittent, is it recurring, those sorts of things. There's no right or wrong here. It's just capturing as much of that as you can helps sort of fine tune how that PCR gets cleaned up and goes out for billing. And again, remember, this is also a legal record. So, capturing that is also covering you as well. Fractures should just be considered in the same way. Describe those fractures, whether they're open, they're closed, etc. We have a little bit in here about acute pain and chronic pain. I'm not going to spend a lot of time here. I think that in your training you get well versed to a lot of this. But we do talk about capturing these details from the biller's side. I have a little clock down here with a reminder that words like recent are very subjective. So when you put something in your chart that says, patient recently gave birth, is that 3 days ago? Is that 3 weeks ago? Is that 3 months ago? Try to avoid generalized words like that and harken back to those specific factors when you can, because that really could mean the difference when the patient gets to the hospital for then the person who's taking over care to kind of understand what's going on. Okay, talked a little bit about that 7th character in the ICD-10 code. That's usually used to distinguish the episode. And what episode is, there are different stages. You have initial, which is the episode of care that is the patient is receiving active treatment. But there's also subsequent and what we call sequela. And those are often used, frankly, more in subsequent transports of like non-emergent transports. Maybe they're leaving the ED and they're going to some sort of acute care facility, some sort of rehab, etc. Sequela is often used when a patient is being transported for care for like a scar from a burn, etc. So those, again, aren't things that you're really going to be thinking about when you're out on the street doing your job, but from the coder, they're using your details to kind of put this together to modify that code that's being used. And again, more common in non-emergent, these latter ones. So we talked a little bit about the logic of writing, and I want to harken back to this and kind of go back to what we talked about in the beginning with the dispatch through the end, with the reminder that in clinical record, legal document, basis of reimbursement, having the mindset that every call is unique is important. If you're out and you do 5 calls a night, getting those charts done in a timely manner helps you keep all those individual details kind of fresh. So thinking about those, writing your chart in a logical manner. I've we used to have a really good example, one that we would pass around at work that was insane. All of private information was blacked out, but it was essentially the EMT was instructed to be more detailed in his or her chart, and so he took it next level, and it read like a Nora Roberts book. It was incredible, and then that person no longer was employed by that agency. But, you know, I think he was trying to get his point across too. He felt like he was doing an adequate, job. So I think that the answer there is there's a balance in between. There's being detailed, but there's not being unnecessarily wordy. And so that's what you should strive for, is just to be clear and concise and have some logic to your writing. So when you're thinking about going back to those main categories, so the dispatch, capturing in those charts, was it 911? And if it's not emergency, which again doesn't apply as much to you folks, explaining why it's a non-emergent transport. Just a quick description of the response being immediate. Skipping down there, if you're using a class system, again, these can vary by jurisdiction. The chief complaint, the patient's reported condition at time during dispatch, and then again capturing it later in the narrative when you actually make contact with the patient and or witnesses about the patient's complaint. The units that are on scene, both your unit and any assisting units, making sure they're noted. This becomes super important in mutual aid calls. So being able to identify who's all there is really important. I know with Calvert County, we're going to be paying a close attention to differentiating between career and volunteer, et cetera. So all that information has to be captured in the chart for us, as well as if you're meeting up with other paramedic units. Scene assessment, just describe what you're seeing. When you get there, quick assessment of take a look around. What are you seeing? What's the situation? Your initial observations, both of scene and of the patient. Make sure you're capturing that. Think of the skin, their eyes, their breathing, etc. Again, back to that reported complaint, because that's going to be a big one. What's the patient telling you? And again, if the patient at this point said that they stubbed their toe in a lot of pain, it doesn't matter. We're still going to look at dispatch, but we still want to capture that. That assessment, this varies how you conduct your assessments. Different mnemonics are used in different areas, and so whatever your protocols and your station wants you to use, focus on that. But capture that and make sure you're including that, whether it's within the narrative or in the flow chart. Treatment and interventions, you definitely want to make sure you're capturing what's being done. As I joked earlier, if you didn't do it, don't say that you did, and vice versa. But also think about the results of those treatments. Even if there's no response, write no response. We want to make sure that we're painting that picture the whole way until the patient ultimately arrives at the destination, right? We want to be capturing all that. Think of packaging. Are you using any bandages? How was the patient boarded? Are they secured in any way? Are straps used? Interesting side note, when we key a Medicare claim, when we get to there's like different tabs and you're putting in different information. And when we get to the one screen, after we complete it, a little pop-up survey comes up. And that's one of the questions they ask specifically about whether or not the patient was strapped. No, just a Medicare thing. But there's like 4 questions on that survey, and we cannot send a claim out until all of those are answered. Patient mobility is huge for non-emergent. I bring it up here because even if it's an emergency call, you still want to talk about how the patient got into the ambulance. There's misunderstandings out there that if a patient walks onto the ambulance that we can't bill that's false. They can walk and sit in the captain's chair if they want. If it was emergency dispatch and you responded, we're going to bill it. But we want to know, were they able to walk? Were they able to walk assisted? Were they unable to walk at all without, capture that, because that does play a role later on in other documentation. As I mentioned, just during transport, ongoing condition, continue to monitor those, in the more severe calls, if you're doing administrations of medication, et cetera, that should all be documented through the flow chart as you're continuing the ride. Transferring the care, talk a little bit about that. Where are you leaving the patient? Are you leaving them in the ED on a bed? Are you taking them to a room? What's the room number? Any details you can provide, excellent for the chart to have. That final disposition of how the patient is when you left him or her. A little note here at the end with refusals. So document patient refusals with the same energy that you would a transport. There's more risk of liability for a refusal, as you could probably imagine. So you're going to definitely want to follow your protocols for that. We're going to get to refusals specifically in a minute, but just remembering, as we did earlier, it's all detail and it's all things. So you can use all of the different ways that we talked about it, whether you're talking about pain, whether you're talking about fractures, whether you're talking about the color of someone's skin or breathing. When you're discussing any of these things, using that kind of detail scale is what's going to be important. And the documentation, as I mentioned, should be completed while it's fresh in your mind. Now, with refusals, specifically motor vehicle accidents, they present heightened risk of liability because at the end of the day, you're recommending them being transported and a patient says, no, I'm fine, I don't want to go. Well, that's great, but if you don't document it and they go home and have a heart attack, you don't really have that record to kind of protect yourself that you went over all of the risks, et cetera, with the patient. So never assume because there's no patient that there's no transport that there's no risks. So follow your protocol, but we are going to talk about here is you want to ensure, the goal is to ensure informed consent, meaning that the patient is of sound body and mind to make decisions about his or her own care. So you're going to be assessing for those. You're going to explain the risk of refusing care. You're going to explain the benefits of proposed treatment or transport. And you're explaining alternative options that may be available to that patient. The threshold for ascertaining a person's mental capacity should be pretty high, meaning you should go in with the assumption that they can make those decisions, but you're going to want to assess for them, and then your documentation should note how you assessed for them. And even if it's just a quick sentence, and then ultimately that says, I determined that the patient was of sound body and mind to make his decision for his care. Document your assessment and your findings, including legal capacity, mental capacity, situational knowledge, if they're aware of the situation, etc. Document your discussions and interactions. That's super important. Capture what you said and your patient's level of understanding. And then document how you obtain the signed refusal form. Signed refusal forms are important. We recommend them in any case. Documented that you consulted with medical command. We're not going to go into facility billing. This is mostly non-emergent transport. We do a whole separate presentation on this. There's a lot of bells and whistles that you have to follow. Hospice is another kind of own little niche. The only thing that I will say about hospice for you guys tonight is this. Another reason why detail and PCR is important is because let's say you're transporting a Medicare patient who is on hospice care. We need to know through reading your PCR why they're being transported, because that ultimately determines whether we bill their Medicare or their hospice. It actually depends on the situation. If they're being transported for a condition that is not related to their hospice care, then we actually bill their Medicare insurance. If it is related to their hospice condition, then we bill their hospice. Again, just why detail is important. Let's see. So we're actually you guys are getting out a lot of this tonight. Well, what I do want to talk about is we have a refusal checklist, and we have a sample on this on our website that all of our billing partners can access, and I can also send it out if you want to look at it. And this is just a go-to of things to check off when you're doing a patient refusal. We use, ours is based on one prepared by a national law group, PWW, and it's just been updated. I'm not sure how aware everyone is with changes in protocols this year, but they did update some of the verbiage used. So previously it was called patient refusal form, but now they're referring to it as a treatment non-transport form, just kind of updating and modernizing the verbiage there. So we actually are getting prepared. We have the updated copy available. The version on our website is still this old one. We have to get our systems team to put the new one up. The assignment of benefits form, that's the one form though that I do want to talk with you all tonight. This is the commonly referred to as the patient signature form. Medicare requires a patient signature for billing. Now, we recommend that every call ends up with a patient signature because you don't really know what a patient's insurance is. So we always recommend getting this no matter the case. If you're having them sign the privacy stuff anyway, having them sign an AOB is just one other signature. So what this does is this allows us to submit their claim to Medicare. There are 3 sections. We have a sample form that we offer to all of our billing partners. CMS does not have a specific form. What they did is they handed out guidelines and ultimately led a lot of people like PWW and us to just create a form to use. So this is one that a lot of our partners use. I've seen slight variations out there, but there's generally 3 sections. There's a section 1, and that is where a patient signs. So a section 1 signature is for the patient, or if the patient is a minor, technically a parent can sign in section 1 for that patient. If a patient is having trouble signing a fully legible name but can make is still able to make an X or something, they can do that, and then you can actually witness it here on the side here. If the patient cannot sign, but maybe a relative, a guardian, someone who handles their affairs can sign, that's a section 2 signature. So that's what they would sign in section 2, and they would write a little explanation of who they are, why they're signing, and then it's dated, it's there. And then finally, if that person is also unavailable, a section 3 is where like a crew member, and this requires 2 signatures. It's usually one of the providers on scene, and then usually someone at the hospital, or if we don't get that second signature, we can use the face sheet as the second part of that signature. So again, it's super important. Medicare will not process a claim without this form. One of the things that we will do is we will send a community resident letter to your residents if there's no signature on file for this, but it slows up the billing, so we recommend getting this. I do believe that there's efforts for the hospital to be getting this when they're at the hospital, so I mean, I would talk that amongst the Calvert County teams to figure out how that's going to play out, but ultimately we would like to see this come in with the chart. Yeah. I'd have to see what it looks like. It has to have a lot of that verbiage that's on the form. So I'd have to see what it looks like in eMeds. I don't know offhand. So it would depend. I'll have to go in, and Larry, maybe you and I can figure out a way for me to see what verbiage is in there. Yeah, it has to have it. So if we back up, let's see. Yeah, it. Yes, there are agencies that use it electronically, but it's been configured to at least give them this information. So it's basically for them to authorize the submission of their claim. Okay, good. Excellent questions, though, because this comes up a lot, because there is a movement. There's a lot of agencies that use tablets now and stuff like that. So they're not carrying around papers for patients to sign. So yeah, this is just a standard form that we have available, but we do have other agencies that get it electronically. It's just they have it into their system built. Okay, let's see. We're not going to worry about pre-authorizations because that's for non-emergent. I think you guys are escaping most of this. See all that fun stuff when you go to a non-emergent transport? Look at that. That's a good question. So that actually came up Tuesday too. So in billing, the way it works is if you have not actually moved the wheels with the patient in the ambulance, then it's a treatment in place. If you take them to a landing scene, we would bill for the transport from scene to the landing zone. So it's just reading your PCR. So if they're transported into the Calvert Health System, we'll be getting that information from the hospital. But if they're transported out of area and ultimately are transported by, we would basically send requests for hospital face sheets, but that would be something to request, yeah, as a hospital face sheet. Yeah. So if it's, let's say you're going to a facility, like the patient's flown somewhere that is not in your agreement, like the network that you're agreeing at, our team would actually send a fax request for hospital information. We would do that. Yeah. Yep. Yeah. We don't want to have to do that often because it slows everything up. And ultimately, if we don't get a face sheet, we have to write it off. But a lot of times in those situations where it's severe trauma like that and they're getting flown, you don't usually have that information. Yeah. One good thing to think about, though, is a lot of accidents like that are accidents. And so if it's been a motor vehicle accident, reaching out to law enforcement after the fact, they can sometimes get that information too. So it'd be helpful for your teams to be able to get that if you can. But again, because one of the things that we didn't really talk about is, so for an auto accident, we actually bill a patient's auto insurance before their medical insurance. So even if the hospital gives us like their Medicare or their Aetna or their Cigna or whatever, if we don't have their Progressive or Nationwide or whatever they have, we have to bill that first. We have to bill that, and then if it's maxed out, then we bill their Medicare or their whatever their primary health insurance information is. Mm-hmm. Right. So for a Calvert County resident, what would happen is we would send them a letter saying, we need your auto insurance. And it comes out in the form, I mean, it's a community resident letter, but there should be space for like signatures and stuff like that. I can't remember what the actual letter form looks like off the top of my head. Yeah. Yeah, so no, our team would do that as part of the quote invoicing, is we would, just like we would for a Medicare signature or any other missing health insurance information. Now, we would do that 3 times, and if they don't respond, then it gets written off. If it's a non-resident and they don't respond, we would send them to collections. Yep. Okay, so a few parting thoughts, and then I'll take any questions you guys have. So EMS documentation is, it's weird, for lack of a better word, but it's so important. And the work that you guys are doing is super, super important, because it really is a glimpse at what starts the timeline for a patient's total continuum of care. And so because of the different roles that a PCR plays, like just having a sense of professionalism and timing and thinking about writing in a clear and consistent manner, it's a reflection of you, it's a reflection of the team that you're working with, and it's certainly going to be in the best interest of the patient. So, just having that mindset that your job isn't done until that chart is our preferred way to go. I know that you guys have kind of standards in place for expectations of turnaround, and that, I applaud that, because it's, not all agencies are successful in getting that in place. But we're always going to be there as a resource. We will give continued feedback on the charts that we're seeing. We're recording this tonight. The client services reps that you guys will be paired with will always be able to answer any questions. If you have questions about a specific situation, the county will reach out to us and say, we don't know how to how we should be handling this. Like, we'll be able to give good feedback on that. We have a lot of resources available, so if there's any additional needs you guys have, don't hesitate to reach out, because we feel very strongly that it's a partnership more than anything. We use words like clients and stuff like that here and there, but most often you'll hear me say billing partner, because it really does rely on communication going back and forth. But our motto is, you do the chart, we do the rest. And so once things are up and running, which has been a long time coming, that's hopefully how it will go. So that, really the only kind of exchange going back and forth are updates about charts, and then, discussions about billing, etc. If you have any questions, I have our website up there. I can give you my card. You're welcome to reach out to me. I don't know if anybody wants to come up and ask any questions here tonight before we close out, but I'm available. And if I can't answer here, I'll get you an answer, I promise.